Well, with that, I think I'm just going to get started because we're just at a couple minutes after the hour. So, welcome everybody to our webinar. Thank you for joining us. And I'm so happy that you're all here to enjoy these amazing speakers who will be speaking about their expertise and their experiences with navigating biologics for people living with arthritis or rheumatic conditions. I'm happy you're here. I know I've been on 3 biologics myself. My name's Lori Prue. I work part-time with the Canadian Arthritis Patient Alliance, and I know it's not easy to understand what's available or how to get it paid and the support available out there. So hopefully you will all enjoy this great content tonight. I just wanted to note that there's captioning available in both English, French, and multiple other languages as well, if you wish to pick another one. I'd also encourage you to participate as you feel comfortable. We are recording this because we will upload it to our website as like an ongoing resource for people who were unable to attend in real time. Feel free to turn your camera off for that reason. And also feel free to put any comments or questions in the chat. I'll be monitoring that as the speakers are speaking. S'il vous plaît, n'hésitez pas à communiquer vos questions en français aussi. Je suis bilingue et je pourrais les traduire et demander au présentateur. Alors, merci beaucoup pour ça. So just a quick, land acknowledgement before we get started. I know we all come from different parts of Canada. I live, work, and play on the traditional unceded territory of the Anishinaabe or the Algonquin peoples in the place known as Ottawa. So if you want to just take a moment to reflect on the lands and the territories in which you reside at this time. I'd also just like to briefly introduce the agenda for today. So we have 3 speakers. And so Megan will start us off by sharing her personal experiences with accessing biologics. And then we're trying to flow things from how a patient or a person living with arthritis would experience these things. So starting with Megan and then ending with Megan, right? So she can sort of, bookmark or sort of the experiences from beginning to end. Like Alexandra Legg will talk about what the clinic visit will be like. Dr. Queen Grundy will talk about what sort of happens after the prescription is written and tell us a little bit about patient support programs, etc. And then we'll have a question and answer period at the end. As I mentioned, I'll be monitoring the chat. We also have a number of questions that we received through various people who registered for the webinar, so we can go through those or go through what's in the chat. So anyways, a brief intro of some of our speakers before I hand it off to Megan Friedman, who will start us off. So here today, as I mentioned in the agenda, we've got Megan, we've got Alex, and we've got Quinn, and they'll present in that order. So Megan, I'm proud to say, came to us. We work closely with a lot of other patient organizations, including Lupus Ontario. So I wanted to do a specific shout out to them because we work together with them on a lot of different projects and initiatives. And so we thank them for that connection. And I know Megan, beyond being an educator and beyond living with different rheumatic conditions, also volunteers with Lupus Ontario and does a lot of great work there. So then we also have, Quinn Grundy, who is a nurse by training and an associate professor at the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. And she's actually done one of the few that I'm aware of anyways, in, sort of research in Canada focused on patient support programs, which is something that many of us will access as we access a biologic or other advanced therapy. And then we have Dr. Alexandra Legg, who is an adult rheumatologist and assistant professor in the Division of Rheumatology at Dalhousie University in Halifax, Nova Scotia. In addition to her rheumatology practice, her general practice, she's also the director of the Dalhousie Lupus Clinic. So with that, I am going to stop talking and I am going to pass things over to Megan to sort of start us off with her experiences. Thank you.
Thank you, Lori, for the lovely introduction. Good evening, everyone. Thank you so much for being here today and for creating a space like this. As a fellow chronic illness sufferer, I know that we only have so many spoons in a day, and for you to take some of those spoons and come here to this webinar tonight, that really means a lot to myself and the other presenters as well. My name is Megan Friedman, and I'm a proud resident of Ontario, a teacher, a wife, a daughter, an aunt, and most relevant today, a disability advocate that works with Lupus Ontario and Lupus Canada, and a living example of arthritis impacting people of all ages. Even though we're not all in the same room, there's something really powerful about knowing that we're all connected through a shared experience, through understanding, and through a journey that none of us chose, but we are all learning to navigate together. A special thank you to the Canadian Arthritis Patient Alliance for the invitation to speak this evening. I want to start by sharing something I think many of us have felt throughout our journey. Something is wrong with my body, and no one quite understands it yet. I learned about this feeling in my early 20s and how quickly good health can disappear. After acquiring a bug bite after a simple summer walk in the woods, I developed flu-like symptoms, except they never ended. Over the following months, I lost mobility, coordination, and very honestly, hope. Doctors speculated about MS. Maybe it's Parkinson's disease, or maybe it's my anxiety acting up. I went from being an active and strong someone who loved running, lifting weights, and hot yoga, to struggling to walk across a room and bathe myself. There were days I typed my graduate thesis in bed using just 2 fingers that didn't hurt, which, for the record, is not a productivity hack that I would recommend to anybody. And I remember thinking, how can my body feel this unfamiliar so quickly? The hardest part wasn't just the symptoms. It was being dismissed. Struggles with anxiety and depression were often cited as explanations for my symptoms. And in one particularly memorable and honestly shocking encounter with a doctor, I was told, "Come on, Megan, you're in your early 20s and you don't have a boyfriend. Are you sure you aren't just making up your symptoms for attention?" I think many of us know that feeling. When you're not just fighting your body, you're fighting to be believed and heard. Eventually, I was diagnosed with Lyme disease. And by the way, having a boyfriend is not a known treatment for Lyme disease, just so everybody knows. And I was diagnosed by an infectious disease specialist in Hamilton. But even after treatment, something still wasn't right. A lot of months had lapsed between onset of symptoms and finally getting my treatment. My body never fully returned to what it had been. A couple of years later, new symptoms appeared: joint pain, sun sensitivity, fatigue, mouth sores, some very strange rashes, one across my face as well. And I was diagnosed with undifferentiated connective tissue disease, rheumatoid arthritis. And to sum up, I was a couple of markers short of the full lupus diagnosis. So I like to say that I was an underachiever in this department. That diagnosis brought something I think we all understand here this evening: relief and grief, all at the same time. Relief, having confirmation of something going on that does have a name, and at the same time, knowing that it wasn't all in your head. But then comes the grief, because a diagnosis of chronic illness comes with the realization that this state of being isn't temporary. There is no cure, only management. and things could get worse without rhyme or reason. For a while, medication layering helped. I found some stability, some normalcy for a period of time. And then the pandemic hit. By 2022, I reached a breaking point. I was relying heavily on prednisone, which, as many of you know, can feel like a break the glass in case of emergency type medication. Except in chronic illness, it sometimes feels like the glass is always just broken. The steroids stopped being effective in managing flares. My pain, stiffness, and fatigue were constant. My rheumatologist knew what I needed. I needed a biologic. But at the time, the system required that I fail multiple medications before I could access one. And I want to pause on that word fail, because what that really meant was that my body had to get a lot worse before I could get better treatment. I felt like a rat trying out a medication, knowing that the answer simply laid elsewhere. Those failures had to be documented and submitted as part of my approval process. Thankfully, the system has improved, and here in Ontario, rheumatologists now have more flexibility to prescribe biologics when they see fit. There's a hierarchy of medications in rheumatology, and I remember my rheumatologist explaining it in a way that really stuck with me. And I'm going to share that with you this evening. She said, prednisone for your body is kind of like a bomb. It works, but it affects everything. Your whole body is impacted through its anti-inflammatory and immune suppressive capabilities. Prednisone also harms as much as it helps, especially with long-term use. This is a chilling reality for folks like me and other people in this call. Just some of the possible side effects include extreme weight gain, tremors, bone density and muscle loss, high eye pressure, increased illness, risk for diabetes, high blood pressure, insomnia, water retention. I'm still rocking my lovely moon face, by the way, that it's slowly coming down as I come off prednisone. Serious mental health side effects as well. Personally, my self-esteem and overall health has been impacted by the drastic changes to my appearance on this medication. I gained 80 pounds over the past 6 years. That's a huge change. Last year, I had to endure laser eye procedures due to steroid-induced high eye pressure, which is apparently a rare side effect, but I had it. Yay! And my doctors have medicated me for severe anxiety and depression, and last summer, suicidal ideation as I continue to taper off of this medication. So, if prednisone acts like a bomb in our bodies, what are biologics? They are the snipers. They target specific parts of the immune system that aren't functioning properly. And I remember thinking, okay, I'll take one immune system sniper, please. And I'm going to turn you over now to Dr. Legg.
Yeah, thank you so much, Megan. We'll pass it over to Alex for the next part of the journey after deciding, or moving maybe from steroids to a biologic, and seeing what it's like from the physician's perspective. Thank you.
Thanks so much, Megan, for sharing the first part of your story. And I know we're going to be circling back to you, hear more of your story in a little bit, and I'm looking forward to that. For now, Megan has paused at the perfect time in her journey. So when she was ready to discuss starting a biologic medication with her rheumatologist. And so in this part of the webinar, I'll be walking you through the clinic visit where we discuss getting started on a biologic and some of the common questions that tend to arise. Before I dive in, I just wanted to quickly mention that I have no financial conflicts of interest to declare in relation to this talk. And I also want to mention that this presentation provides a general overview of the process for initiating biologic therapy for inflammatory arthritis, whether your diagnosis is rheumatoid arthritis, psoriatic, lupus, ankylosing spondylitis, etc. And so this information really is intended for educational purposes only, and does not replace, obviously, the personalized advice from your rheumatologist, which certainly may vary for a number of different reasons. So I'd like to start with a quick overview of the medication options for the treatment of inflammatory arthritis and where biologics actually fit within our overall treatment approach. And so first we have symptomatic therapies, things like nonsteroidal anti-inflammatories or NSAIDs, as well as corticosteroids like the prednisone that Megan has already mentioned. And so these are really potent anti-inflammatory medications that work quickly to provide symptom relief within hours to days of starting the medication. And so this is helpful because these are therapies that can be really useful as short-term bridging therapies when people are really severely disabled or affected by their symptoms. However, and again, Megan has already alluded to this, these are not great long-term therapies, in part because of their side effects, and also they are not good long-term options on their own because they're really not addressing the underlying autoimmune disease process or preventing it from progressing to cause permanent damage. And so this is really why we need what's called disease-modifying anti-rheumatic drugs, or DMARDs. So these are medications like methotrexate, like biologics, that really modulate or suppress the immune system to stop disease progression in its tracks and to really prevent the development of irreversible joint disease. However, I should mention, and many of you are already aware of this, that the onset of action of DMARDs is much slower when compared to things like prednisone. So here we're really looking at anywhere from 6 to 12 weeks in order to see the full effect of a DMARD on disease activity.
I'm beginning with this. Daddy, I'm eating fish taco. And thank you for the stuff.
There are also many different types of DMARD therapy. So the first being conventional synthetic DMARDs. So these are things like methotrexate, hydroxychloroquine, leflunomide, sulfasalazine. So really the first-line medications for conditions like rheumatoid arthritis or psoriatic arthritis. These are older therapies, so they've been around for a long time. They're mostly oral therapies, with the exception of subcutaneous methotrexate. And in general, they tend to be fairly affordable, although sometimes medications like leflunomide can start to get a little bit pricey. These drugs really have very complex mechanisms of action. So in some cases, we still don't fully know why methotrexate works as well as it does for inflammatory arthritis. So they tend to have really a broad range of effects across the entire immune system. And for a long time, these were our only DMARD options for treating inflammatory arthritis. But luckily now, over the last couple of decades, we've seen a huge development in advanced therapeutics for inflammatory arthritis. So these are newer, more expensive therapies that tend to target very specific parts of the immune system. So they're interrupting these key pathways that are overactive in autoimmune disease and that are driving the joint inflammation. Most of these advanced therapeutics are biologics. So these are medications that are engineered or manufactured from living cells or organisms. And one of the most common classes of biologics that we use for inflammatory arthritis are the TNF inhibitors, of which an example would be adalimumab or brand name Humira. We're also now seeing another class of advanced therapeutics that I just thought I would briefly mention, which are the targeted synthetic DMARDs. So an example here would be the JAK inhibitors like Rinvoq. And so these medications are a little bit different from biologics because they're not engineered from living cells. They're engineered chemically in a lab, and but they do have important similarities to biologics in terms of their expense, their targeted mechanism, and their side effect profiles. And so a lot of what I'm going to describe here would apply to targeted synthetics in addition to biologics. Megan already alluded to criteria for starting biologic therapy, and these are really established by public and private payers in terms of the circumstances where they feel these therapies are cost effective and therefore where they're willing to provide coverage. And so the exact criteria for coverage really varies depending on the disease, as well as what province you live in, and even just what type of insurance plan you have. And so here, just as an example, again, this will vary widely across the country, but I've just provided a few examples of criteria for coverage from the province of Nova Scotia public pharmacare formulary. So this is the province in which I practice. And generally, as Megan alluded to, you need to fail a number of standard non-biologic therapies before you would be eligible for coverage of a biologic. There's so many different classes of biologics now, and often even multiple different drugs within each class. And so the options can really seem overwhelming. I really think a great question to ask your rheumatologist during this clinic visit is, which biologic is right for me and why? So there are many different factors that would go into the decision of which biologic I might recommend for a certain patient. That includes their specific disease, their disease manifestations, their other medical comorbidities, and then even in some cases, their family medical history. And so unfortunately, at this point, we don't have a good way to predict which person is going to respond well to which biologic. That's the dream, but unfortunately not yet a reality. And so at this point, it's still sometimes a little bit of trial and error. And so I usually try to reassure patients that even if the first biologic we try isn't effective, we have lots and lots of other options. And sometimes it's just a matter of finding the right one. There are a few other factors I thought I would mention that I think patients should really consider from a lifestyle perspective, especially if they're choosing between a few different biologics where all other things might be equal. The first would be the route of drug delivery. So biologics generally don't come in pill form. They're either given through an intravenous infusion, which is usually given in a healthcare setting by a nurse, or given as subcutaneous injection, which can be self-administered at home once you've received some basic training. And so there may be different things to consider in terms of how each of those would fit into your current lifestyle. The other thing I would mention would be frequency of dosing. So there are some biologics that are dosed once a week, some once a month, and some even less frequently. And so that may be something else to consider. One of the most important things that we talk about during this clinic visit is side effects. So which side effects should I watch out for? For medications that are self-administered at home by subcutaneous injection, one of the most common things we see are injection site reactions, so pain, itching, or redness at the site of the injection. For intravenous medications, we can sometimes see almost like allergic-like infusion reactions that occur while the medication is being given. And so that's why it's given in a monitored setting by a nurse who can intervene if needed. One of the most important aspects when we think about biologics is they do have a significant immunosuppressing effect, more so than some of the conventional agents that I mentioned earlier, like methotrexate. And so the risk of infections is certainly something that we do need to consider here. One of the ways I sometimes frame this to patients is I would say that if I gave 100 patients this medication for 1 year, 3 or 4 of them would have a significant infection requiring antibiotics or a trip to the hospital, compared to maybe only 1 or 2 of them if they weren't taking the biologic medication. So this sort of gives a bit of a sense of how frequent infectious complications are with these medications. The other question that often comes up is the risk of cancer with these medications. And certainly with any drug that suppresses your immune system plays a really important role in surveying the body and looking for and protecting against the development of cancer. So anytime we're suppressing the immune system, theoretically, this could increase cancer risk. I have to say in inflammatory arthritis, this is very hard for us to study because patients often have multiple different exposures to different medications. And there's also a baseline increased risk of cancer with some of these conditions, like rheumatoid arthritis, for example. I would say, speaking specifically about TNF inhibitors as the class of medication that we probably have the most evidence for at this point, I can say that overall, the data has been reassuring, suggesting that there really is no significant increased risk of blood cancers or solid organ cancers with TNF inhibitors. Possibly a very slight increased risk of non-melanoma skin cancers. And so we do recommend regular skin checks for patients who are taking these medications. But otherwise, I think we can be fairly reassured by the data we have so far about cancer risk with biologics. With the immunosuppression and infectious risk with biologics, there is some pre-biologic workup that must be done before we can start the medication. This is because there is a chance for reactivation of latent infections that are lying dormant in the body. And so typically the things we need to check for before starting a biologic would be tuberculosis or viral hepatitis, like hepatitis B or C. Most of the time, this is done using blood tests, one for tuberculosis and then others for hepatitis. And so these are very critical tests that we need to have results back for before we can start the medication. In terms of infection risk and how to protect oneself, I often get a lot of questions about how careful we need to be when taking a biologic medication. I think there are lots of common sense things that one can do to try and protect themselves, such as avoiding sick contacts when we know people are unwell, considering wearing a mask in very crowded places, such as on airplanes, and just practicing good hand hygiene. But overall, I reassure people that you can still live a very full and normal life, and you don't have to be in a bubble just because you're on a biologic. Another thing that we often talk about during this clinic visit is vaccinations. In the interest of time, I'm not going to get into this in detail, but certainly it's something we can cover in the question period if there are questions. But definitely updating vaccinations is an important part of the biologic initiation process. Another question that I get a lot is what happens if I get sick? I think it's important whenever you're seeking healthcare, whether it's a walk-in clinic or an emergency department, to always make sure that healthcare providers know that you're on a biologic so they can consider this in their treatment plan. Generally, we don't need to hold biologics for mild illnesses like a common cold, but usually if it's a more significant viral or bacterial infection, I would advise holding the biologic until treatment is completed and you're feeling better. Similarly, it's always important if you're undergoing a surgery or procedure to make sure that the surgeon is aware of the biologic medication you're taking. Typically, they don't need to be held for more minor or low risk procedures, but usually we do recommend holding the biologic for a period of one dosing cycle preoperatively for higher risk surgeries. And then the medication can be started postoperatively once the wounds are healing well and there's no signs of infection. For females of reproductive age who may desire future pregnancy, I would definitely encourage you to speak with your healthcare providers about the pregnancy compatibility of biologics. At this point, I should say that biologic medications, these are large molecules, and so they don't cross the placenta until late in pregnancy. And so in general, they're theoretically thought to probably be fairly safe. But from a data perspective, we really mostly have safety data for the TNF inhibitors. And so at this point, it's felt that these are likely fairly safe to be used throughout pregnancy. And in particular, one of the TNF inhibitors, Cimzia, has a special format that means that it doesn't cross the placenta at all. And so this is generally felt to be the most safe biologic during pregnancy. As well, biologics have minimal transfer into breast milk and very limited systemic absorption in infants fed breast milk. And so they're felt to be safe during breastfeeding as well. Another question is, do you continue your other medications once starting biologics? And I have to say, so symptomatic therapies can certainly be continued if needed, especially if biologics are being started in the context of a disease flare where they're going to take some time to start working. When it comes to your other medications like methotrexate, for example, whether or not to continue that with the biologic is a very individualized decision. I would say in general, we tend to stop those medications more when starting biologic for things like psoriatic arthritis, where typically in rheumatoid arthritis, the methotrexate would be continued in combination with the biologic. Again, very, very individualized and something to discuss with your doctor. So once we've gone through this counseling and decided on a biologic therapy to start, then comes lots of exciting paperwork. So this is an example of an enrollment form that we would complete in clinic. Each biologic medication has one. So this really serves as the prescription for the biologic, and it gets faxed to the patient support program to start the process of enrolling you and initiating the biologic. So in our planning call, we talked a lot about the phone call that happens. And certainly that's often how I close these clinic visits, is to advise patients that the next thing that they will hear is a phone call from the patient support program where they'll be discussing next steps. And so with that, I'll hand it over to Quinn, who will talk about what happens from there.
Thanks,
Yes, thank you.
Alex. Hello, everyone. It's a pleasure to be here. Bonjour. I'm going to just share my presentation. While I'm doing so, I might just ask if you're comfortable with a thumbs up or not. If you've had any contact or know what a patient support program is, perhaps give me a thumbs up. I'm going to just switch this view. Okay, there's a couple there. Okay, well, I'll see how I go here, and I see how is that. There's at least I see 3 or 4. Okay, so some of this may be old news to you, but glad to hear that there's some touch points. So I am a registered nurse. I work at the Faculty of Nursing at University of Toronto, where for the last couple of years, we've been doing a study to try and understand this landscape of what are called patient support programs. And it will be news to some of you and not to others that this is the pathway by which people who are prescribed biologics in Canada receive care. I'll just acknowledge that this research has been funded by the Canadian Institutes of Health Research and the Social Science and Humanities Research Council. And I also have received payment for consulting with the Government of Canada, the Competition Bureau, on these topics. So, by way of introduction, patient support program is something that pharmaceutical companies designed and came up with as a way to remove barriers to access. And this story kind of begins about 20 some years ago when one of the first biologics to come to the Canadian market, the originator of infliximab, also known as Remicade. The clinical trials for this drug had happened in hospitals. And in Canada, we're very proud of our Medicare, but it will cover anything that requires physician services or which requires someone to be hospitalized. And so when it came to figuring out where people were going to get an IV infusion for this medication or injection training, things that don't require hospitalization, don't require a physician, there was a gap. And as people have alluded to, this was also the most expensive drug to ever hit the Canadian market. And there was a bit of a pause while systems were trying to figure out what this looked like. Pharmaceutical companies are very good at surmounting barriers to access when it means getting their product out and finding its market. And so we've done surveys, and I would say in Canada, the number one role that patient support programs play is figuring out how someone will pay for or afford the drug. As you know, we do not have a national pharmacare program in Canada. And last estimate I heard, there are tens of thousands of different private insurance plans. There can be multiple insurance plans in a single family. People go through multiple insurance throughout their lives. Depending on your province, you may have public and private insurance or just public insurance. It is a really complex landscape to navigate. And Dr. Legge has well alluded to the fact that they all have different forms. They all have different criteria. And many of this is really about trying to kind of manage some of these costs. I'm sorry, my slides are going crazy. And so once you get that call, it probably means that you are on one of these biologics. I'll just say that at this point, these have really proliferated in the Canadian market. Now we have counted, we went to look for them all. 1 in 10 drugs have a patient support program, but these are really concentrated among the biologics. Many of them are also drugs for rare, these chronic diseases. And we've talked a lot about kind of the cost in these expensive drugs. And I just want to emphasize that these patient support programs are very much included in the cost of the drug. Patients are not paying for this out of pocket. Insurance is not covering this. Our health system is not paying for these services. But pharmaceutical companies are really only providing these services where it's kind of commercially making sense for them. And so many of the other therapies, like methotrexate, prednisone, that are heavy duty, require injection, unfortunately don't have these kinds of supports. So Dr. Legge showed you an enrollment form. I picked up another one just as an example. This is the prescription, this is the fine print, and it does require your consent. But it's a strange situation in that I actually have not heard of somebody declining this and still getting access. It's a little bit unclear to me what, and Lori and I have talked about this to some extent, what happens if you don't want to be in the patient support program. If anyone finds out the answer to that, please let me know. But after that, you are going to kind of go on a different journey into this other care system. And so your specialist will provide your diagnosis, discuss the treatment decisions, this is the place for your questions and concerns. But once you get that phone call, you'll be speaking with a case manager. That person may or may not be a registered practical or registered nurse. And they're the ones that will actually collect your detailed medical history, about the treatments you've tried that worked or did not work, about your current symptoms. They may be administering a symptom score or questionnaire to understand where you're at. And they are the ones that are going to fill out and identify whatever forms are needed to ask for special authorization or exceptional access or permission to get the drug covered. And I think what I'll talk to is that it has a really nice name, patient support program, and it presents kind of as a one-stop shop, but it does require navigating multiple different entities. And unfortunately, I think that requires often that patients kind of manage and navigate that and coordinate these many cooks in the kitchen. And so the PSP, that case manager, is going to be the one that does that reimbursement navigation, maybe coordinating with your doctor's office to get their signatures, the insurance. They'll book you in for your first infusion at a clinic near you if you are on an intravenous med, and they'll coordinate with the pharmacy. Then you kind of get passed along. You'll probably be dealing with a specialty pharmacy for ongoing refills, drug delivery. You'll meet a nurse in the infusion clinic and they'll often schedule your ongoing infusions. But you'll come back to that PSP. Many insurance companies require that you get that authorization every year, that it gets renewed. And so it's a bit of a loop as I have here. So thinking very practically about what to expect. I think in our research, we've been talking to people who are prescribed biologics across Canada. Probably about half of them are living with arthritic conditions. We're also talking to physicians. We're talking to the people who work for these PSPs to understand what this experience is like. And I think, like everything in life, there is a variety of experiences. But these are just some things that I wanted to share that I've heard in our learnings to consider. So, the PSP will give you a call, but think about the level and type of communication that you wish to have. And you might even ask them about the roles and responsibility. You might be traveling. You might have different work schedules, caring responsibilities that again affect your decision about where you get that infusion, whether your drug is delivered. Do you want to be CC'd on the communications with your doctor, or you rather it happening in the background? I think many people do find they have to continue to check in with the PSP to make sure that form got signed, that it got submitted, that the refill was initiated. A huge issue is affording these drugs. Sometimes, even if your insurance approves it, there are considerable copays, deductibles that are out of reach. I encourage people to ask the PSP about financial support. Sometimes that is available. Sometimes, though, people are in a situation where it is not affordable. And I think at this point, even though doctors are not managing this part of it, it's important to talk to your doctor about that reality and ask about alternatives. When you get to filling the prescription, many patients then receive their biologics through a specialty pharmacy. And many of these companies that run PSPs actually also own these specialty pharmacies. And so they tend to like to keep it in-house, in network. But you as a patient can consider, do I want my biologic filled by my regular pharmacist if that's possible, and advocate for that. Sometimes insurers actually require or incentivize that you fill the prescription at a particular pharmacy, and the PSP needs to know that. Often it defaults to delivery to the infusion clinic or delivery to your home. But if you're someone who lives in a big apartment building or works shift work, that might not make sense for you. And so I encourage people to advocate for your situation. Similarly, if you're traveling, if you're going somewhere warm for the winter, the PSP can be the one who can help you kind of figure out how to make that work logistically. And then how do you actually get the medication? In Canada, as I mentioned, we have this strange situation we've arrived at that depending on the type of infusion drug you are prescribed, you will receive your care in different settings. And so what has happened is it's bifurcated that chemotherapies, blood products, plasma, iron, bone, a lot of that is done still in medical day units, ambulatory care in our publicly funded system. But when you're prescribed a biologic, a biosimilar, or immunotherapy, you are getting those medications administered either, first injection training, or an infusion in these private infusion clinics that are funded and operated through the PSPs and by the drug manufacturers. The PSP kind of coordinates this. The clinics are staffed by nurses who will safely administer that medication and book the subsequent appointments. But I think the biggest challenge that patients face is if you do end up switching drugs, it means going into a new patient support program and often even changing where and how you get your medications because these programs are set up to be brand specific. So a few takeaways, and happy to answer any questions, but I think despite it kind of being advertised as a patient support program, realistically, many people find they have to kind of case manage their case manager, and having that expectation made it a little bit easier to stay ahead of things. I think people, and Megan has alluded to the fact that living with a chronic illness is like having another job on top of everything else that you do. And so I think it is important to be upfront and find and activate additional supports for all this labor that people have to do. I'd also just kind of suggest that your physician and your physician's practice, maybe there's other clinicians, other members of that team, really should still be your primary point of contact for side effects, questions, concerns about treatment, even affordability. If you also have issues with the PSP or the care you receive, although it seems like it's part of the system, there is no kind of standardization or mechanism for coordinating care. And so the physician and your team and your healthcare team really does need to know when you're running into issues, and you shouldn't assume that that information is being fed back. So I think I'll leave it there in the interest of time. And thanks, Lori.
Yeah, no, thank you so much. And Megan, I don't know if you wanted to come back on for your,
Yeah, I'm on my way. One second.
And I would just ask if folks are open to it, we can stay on for maybe another 10 minutes to answer questions if you're okay. I know there's lots of great information, so I hate to limit any of the talk and all this good information that folks are getting. So thank you.
Great. So we left off with my story as I was talking to my rheumatologist about starting a biologic, and I was getting the phone call from my patient support person. So in my case, my first biologic was Actemra, which is commonly prescribed for the treatment of arthritis. And at the time that I was prescribed Actemra was also being used to manage long haul COVID. And it was 2022, so the pandemic was, still quite problematic. And people were needing the at-home injections in order to isolate and receive treatment for long haul COVID. So I started with infusions. So I had about a 3-month wait to access my biologic. I missed work during that time and relied heavily on steroids. And on my wedding day, I left my reception at 9 p.m. because I was too fatigued and sore with my joints to be able to really enjoy my wedding day, unfortunately. And when I finally started biologics, improvements were not instant, as Dr. Legg alluded to. So it took about 3 to 4 months for me to really start to feel like myself again. The inflammation slowly decreased, the pain softened, and my energy came back. And my body just started to feel like mine again. And I started with monthly infusions because I wasn't able to access the at-home auto injectors at that time. And for some people, that works really well. For me, the monthly infusion was not my favorite mode of delivery for the medication. I would often become quite dizzy during the infusion, and they would have to lie me back in the chair, and I'd have to stay a little bit after to make sure I felt okay in order to head home. But again, everyone's body is different, so the monthly infusion might work perfectly for your lifestyle and you might not have any of those side effects. And I also found that with monthly infusion, in my experience, I would feel the medication wearing off. So about the week leading up to my next infusion, I would start to get sore again, and I would be like, oh, it's infusion time. So we switched actually to the auto injector pen, which I have here. So this is my Actemra pen that comes every month. It's delivered to my house. And again, depending on whether or not you're comfortable with needles or not, you can really learn how to inject at home. So we talk about the patient support program as well, and the clinic that you would say get a monthly infusion at. There's often nurses there that would help you self-inject once a week. So that's an option. Also, your local pharmacy can help you. Your family doctors often have nurses that work in their clinic, so you can go there and get an injection if you're not comfortable doing it yourself. But I find it's pretty easy. So, and you just keep rotating sides on your body. They'll show you a map of where it's okay to inject. You just keep rotating injection sites. And this one, I like the Actemra pen a lot because it has a handy button. And by the way, I'm not sponsored by Actemra or anything. I'm not trying to sell you this medication. But it's a little button at the end, and it's spring-loaded, so you don't even have to worry about jabbing yourself quickly. It kind of does the job for you. So it's really easy and really convenient. And the best thing that I found was that there was no wear off. So each week I just inject myself and I feel great all the time. And that auto injector really made a big difference. I had fewer side effects, more consistency, and a lot more independence. So I can travel very easily. I have a little medication cooler that I take with me on planes. And then that goes through security, and I keep my medications underneath my seat on an airplane, so I can travel. So Dr. Legg was alluding to quality of life, right? So I am able to go on an airplane. I am able to travel, and the medications stay cool and can even be, depending on the temperature, left out a little bit as well. So that's okay. And alongside medication, I've explored other ways to support my body. So it's important, often with biologics, there is a sun sensitivity that comes with that. So being very vigilant about my sun protective clothing, my sunscreen, and making sure that I'm not, sitting in the sun for too long and that I have shade options is really important. Also, I have found that just being proactive in different ways. So doing things like yoga, Pilates, making sure that I'm taking good care of my muscles so that my joints are supported. I'm managing my stress, and working on mobility and strength. Personally, I like to go to osteopath, massage. I've had some acupuncture, different Chinese medicine options. But again, there's a caveat here. We are all wonderfully different. And what might work for me might not work for you. And you should always check with your rheumatologist, with your care specialist before trying any alternative medicines or therapies to make sure that that's okay for your body. Another way that I like to be proactive is I like to stay up to date on my vaccines. I'm an elementary school teacher, so I encounter a lot of germs, and I get a lot of hugs. So it's really important that you watch your hand hygiene. I personally, cold and flu season, I don't share food at work, and I wear masks sometimes as well when I teach if I know there's no outbreak of something in the school. And I also have this page that I take to the medical appointments in the ER. So what I like to do is I have a Word doc in my computer. I've made a little chart. Up here, I've listed all of my diagnosed conditions, all of my specialists and their contact information. And then I have all my medications, and I just update as things change. So right now I'm tapering prednisone. So the prednisone line, I'm updating, I'm at 3 milligrams and all of that. So I take this with me if I have to go to emerge. My husband keeps the copy with him as well. So that way, if I ever can't speak for myself, my page does. So those are just some ways of making sure, because I am, as you will learn in a minute, on 2 biologics. So I have to be doubly careful to make sure that everybody knows that I'm on prednisone, which can affect care at times depending on your dosages, as well as 2 biologics. So those are some things to keep in mind. So one of the most impactful parts of my journey was the patient support program, because biologics don't just show up at your door with a good luck note, okay? There are approvals, scheduling coordination, and when you're already not feeling well, that can feel like a lot. And being chronically ill, we're often managing multiple conditions. So the support program helped me navigate everything. But more than that, it reminded me that I wasn't just a patient, I was a person. This past year has brought me another devastating chapter in my health. After bronchitis in the fall of 2024, I developed severe persistent breathing issues. Airway inflammation so intense, I lost my voice, struggled to even bathe myself or get dressed, and even left work one day in an ambulance. What I believed would be a few days off work with some extra high-dose prednisone turned into a year-long medical leave, high-dose prednisone use, and an LTD claim. ER visits, failed treatments, and endless consultations defined those months. I was battling not just for my health, but for the ability to breathe, to speak, and to return to the career I love so deeply. Because being a teacher is not just what I do, it's who I am. And once again, a biologic helped. This past fall, I returned to my full-time duties as an elementary school teacher. And this is the biologic that saved it all. This is called Dupixent. And this is prescribed for psoriasis as well as eosinophilic asthma, which is my diagnosis. And I was within 2 years of having a very different future. So this is only 2 years old. And previous to, like in the past, I would have been placed on high-dose prednisone for the rest of my life, because that was the only option that existed, and that was the only treatment that existed. And I would have probably had to quit teaching because I was struggling so much to get my sentences out. And I would have had deterioration in my health, ended up on oxygen. So now I'm sitting here talking to you and yakking your ears off because of this guy. So these are miracle drugs, as far, in my opinion. So this past fall, as I said, I returned to full-time duties as an elementary school teacher. And today I speak before you using the very voice and breath that were taken from me a year and a half ago. I am now down to 3 milligrams of steroids. And I'll be off this medication completely for the first time in 6 years this summer. Biologics didn't give me my old life back, but they gave me something just as meaningful, a life I can participate in. Because of biologics, I can work, I can move, I can be present, and I can even plan for my future. And if you're here today, still waiting, still trying treatments, still feeling discouraged, I just want to say you're not alone. This journey is hard, but there is hope, and there is a community like this one that truly understands. Living with arthritis changes you, it challenges you, but it also builds resilience in a way nothing else can. For me, biologics were a turning point. It is important that we do not think of them as luxuries, but as lifelines. And when we talk about things like affordability, some patient support programs there's a deal sometimes with the maker of the biologic where they'll cover you for so many months as you try to get other funding arranged for yourself. So that's something to consider. And also biosimilars are coming out, which are basically stabilized versions of biologics that already exist, and they're much more affordable. So we are going into an era where biologics will be easier to access. And Lupus Ontario right now is advocating that the province actually cover biologics in their entirety. So we have some exciting things coming up in terms of affordability. And these drugs prevent irreversible damage to organs and joints. They preserve a person's ability to work, to care for their families, and to participate fully in society. Thank you so much for being here this evening and for listening to my story.
Great, thank you so much, Megan. And I'm glad. I know I'd like to kind of look at things in a similar way, and that I've lived with these with juvenile rheumatoid arthritis for much of my life, and it gives you a different life, right? And but I do think it kind of shows our resilience, right, through a lot of these challenges, and it shows us maybe something we never saw before, right, and that maybe others haven't even had a chance to discover for themselves in terms of fresh looks on life and these sorts of things. So not to say it isn't easy. It's very challenging, but anyways, thank you so much for sharing that. I know we're a little past the hour now, but like I said, I didn't really want to. There was lots of great content, so I'd rather sort of cover have a chance for everybody to have their say. So I'm just going to put our panelists on. Sorry, just going to spotlight, or hopefully I could spotlight multiple. I'm not sure. Let me try this. Add spotlight. I'm going to add another spotlight for you, Alex. Thank you so much. And I guess myself, though, I'm a little less important today. But anyways, I thought I'd go through. I know there was a few in the chat, in terms of questions. So I might start with a more specific one from the chat and then maybe move to a couple broader ones that we got through the registrations. Because I think, if you wanted, you had the chance to kind of put out a question there. But there was one around, and I might direct this one to you, Alex, if you're okay, in terms of you talked about a lot of the different treatment options, and there's a good few now, right? In particular with rituximab, how many infusions can one expect with that? Because, you did talk about the timing being different for each one, and this one's a little more unique. So maybe I'll pass that to you for answering.
Sure. So, yes, the rituximab is a little bit different from a lot of the other biologics. So it's given as an IV infusion. Typically, at least the first course of therapy, it's usually 2 IV infusions 2 weeks apart. And then typically we wouldn't retreat with rituximab again for at least 6 months after that. And really, decisions around how often to retreat and what dose of rituximab to use when we retreat. It's very individualized. It depends on the patient and the disease that we're treating and the severity. Some patients, like for instance, my mom has rheumatoid arthritis and she's gotten 2 grams of rituximab every 6 months for the past 20 years. So there really is not necessarily a set maximum number of infusions that someone can get. One of the things that we do worry about with rituximab is, of course, it's probably of our biologics we use for inflammatory arthritis, probably one of the more immunosuppressing. So the risk of infections is fairly high. One of the things that we keep an eye on in patients on rituximab is their immunoglobulin levels on their blood work. We'll usually check those before each course of treatment to ensure that those levels aren't getting too low, which with rituximab can be an indicator or a sign of increased risk of infections.
Right. Yeah, I know. Okay, no, that's good to know. I know it's pretty unique in all the ones out there, but I know lots of folks who take it and it was worked quite well for them. It's always a, individualized thing, as you said, but anyways, thank you for that, Alex. We did get a number of questions, I would say, in the registration around kind of like, why do, just generally about biologics. So like, why do biologics lose their effectiveness over time? Like I've been on 3. I mean, that's spread over 20 years. Like that's it's a long time. But, Alex, I don't know if you would have any, broad advice to give around that. Like, why does this happen to us? Like, why do we have to switch through so many times,
It's a great question, and I'm not sure we have all the answers for why biologics lose efficacy over time. And of course, as people, with experience with biologics, that everyone's different. So someone might be able to take one biologic for 20 years and not need to switch. And for another person, that same biologic may only work for a year or two before it starts to lose efficacy. There's some thought that maybe it's just the autoimmune disease itself that's sort of changing over time. And so maybe it's just different pathways leading to inflammation. And so maybe we just need to target something different over time. There's also this idea of the formation of anti-drug antibodies. So your body actually, once it's been exposed to the biologic, can actually make antibodies against it that can make the biologic less effective for you. And so some of the things that can play a role in terms of preventing the formation of anti-drug antibodies, that's one of the big reasons why we'll often recommend that people continue to take a conventional medication like methotrexate along with their biologic, because the thought is that the methotrexate, it's not so much doing the heavy lifting anymore in terms of treating the arthritis. It's preventing the formation of those anti-drug antibodies to make sure that your biologic continues to work for you long term.
Interesting.
The other thought, I don't know how much data there is around this, but one other thought is if there's a lot of interruptions in therapy or sort of like intermittent exposure to a biologic, that maybe that could be a risk factor for formation of the antibodies. And so that consistent dosing is another thing that might help with prevention there.
Yeah, right. Okay, interesting. Yeah, I know. I know we have a resource too on the methotrexate as kind of the backup. Anyways, I could share it afterwards with folks because I know it's not always like an easy medication to take, that's for sure. And but I know I've managed to get myself back on it, but it's challenging, at least beyond pregnancy. Really glad you covered that on pregnancy, by the way, because it does change things up quite a bit for people. There was one in the chat, and then maybe I'll close things off in terms of some of the eye pressure side effects. So maybe, Megan, you spoke a little bit about that in your presentation, and then I'll maybe ask anyone else on the panel to sort of chime in terms of maybe being possibly related to prednisone. So maybe you can comment.
Um, I'll comment briefly, but I don't want to like overstep with expertise because I'm sure Dr. Lake or Professor Grundy could probably speak a little bit better on this. But so what happened for me was the year I went through my lung issues, I was on 50, 60 milligrams trying to figure out if we could get my lung inflammation to come down. And just with being on such high doses for so long, I started noticing that my vision was hazy. So I went to my optometrist, and my pressures were like in the high 30s, which is very high if you're not familiar with eye pressure. So I was sent then to an ophthalmologist who tried to bring down the pressures with drops. And then the drops were ineffective. So they did what it's called a laser procedure, where they actually put little drainage holes in your eyes with lasers. And it allows the pressure in the eye to come down. And ever since that happened, no eye pressure issue. But it's really important. For myself, like I said, it's been 6 years on prednisone at all sorts of doses for all sorts of reasons. If you're someone who uses prednisone a lot and has had to, just if you notice any little changes in your eyes, don't think that you're just making it up. Go and get it checked, because high eye pressure can cause permanent damage. So we don't want to mess with our eyes. Go get it checked.
Yeah, we should. I don't know if anybody else had they wanted to add around the eye related issues with steroids possibly, or
I would just say that certainly that elevated intraocular pressures can definitely happen with steroids. As you said, Megan, it's not one of the more common side effects that we tend to think about, but it's certainly well described. And then the other big eye side effect that we see with long-term steroid use would be cataracts, are very common in association with steroids. And I find the other thing I'll just mention is oftentimes we do see people have these sort of changes in their vision with high dose steroids. And so I would just say not the time to go get your new like prescription lenses when you're on high dose steroids because it can really affect things.
Right. No, that's good to know. There's a lot of eye considerations in general, right? With all of these medications, so anyways, good probably worth a topic in and of itself for a webinar when, one of these days. So, well, anyways, thank you so much. In terms of, I think at this point I'll sort of close things out, and I really thank you, Megan, Quinn, and Alex, for sharing your perspectives and really I think giving people a good sense as to what things look like in trying to get on a biologic from beginning to end, from the clinic visit to you're not feeling well at home, etc., to the patient support programs. So thank you so much. And thank you, and like everyone, for staying on a little longer so I can at least get through a few of the questions. And I see lots of thanks in the chat. So have a nice evening, everyone. And we'll share this recording with you afterwards as well.